Yes, I can see.
Okay, so good morning, everyone. I first want to thank you for giving me the opportunity to speak today. My name is Jenna Hannouille. I'm a plastic surgery resident currently working in Brookman Hospital in Brussels, and I'm affiliated to the Free University of Brussels. Today, I want to present to you a very unique case we had to manage a few years ago, which was a breast implant infection with Pasteurella canis, which represent the first case report in the literature. So first, I have nothing to disclose. Let's start with our case presentation. We had a 59 years old woman presenting at our emergency department with the following complaints. She was complaining about pain in the right breast associated with an active nipple discharge, redness. She wasn't having any fever or chills. Actually, the initial onset of symptoms happened 2 months earlier with pain, swelling, and redness of the right breast. She was empirically treated with amoxicillin and clavulanate for a supposed mastitis for approximately 10 days. We could observe an initial improvement of the clinical and biological state of the patient, but then there was a recurrence of the symptoms even through an extended antibiotic therapy. So if we look at the senologic history of this patient, in 2001, she was diagnosed with an invasive ductal carcinoma of the right breast, treated with mastectomy and complete axillary dissection. She got adjuvant hormonotherapy with tamoxifen. In 2003, so 2 years later, she got a right breast reconstruction with an expander in the right side, and the left breast was symmetrized with an implant. In 2015, both implants were repositioned and the right expander was refilled with saline. And in 2017, the left implant was removed and the expander was changed for a definitive prosthesis. So as you can mark, there was quite a long time between all the surgery. That was due to a quite uncompliancy of the patient. And it is important to notice that the last surgery in 2017 happened 7 months before the emergency department consultation. She had no other medical condition and she wasn't taking any medication. So for the lab result, we could observe that she had a major inflammatory syndrome with elevated CRP, elevated fibrinogen level, and an elevated sedimentation rate. The other parameters of the lab were normal, and a pus swab was performed upon admission. For the treatment, we indicated immediate implant removal, but the patient preferred to postpone the intervention due to personal reason. So the surgery was performed 4 days after admission. We performed an implant removal, of course. We made perioperative sample. The implant pocket was extensively cleaned with saline and povidone iodine, and then we put a drain after the surgery. She received IV amoxicillin and clavulanate, which was switched per us upon hospital release. For the evolution of the patient postoperatively, we could observe the clinical and biological improvement since day one postoperatively, and a complete symptoms relief after 3 days. The drain were removed when giving less than 30 cc at day 3, and she got discharged from the hospital at day 3 also. She got a total antibiotic treatment of 10 days with amoxicillin and clavulanate. The control consultation after 2 weeks, she wasn't showing any symptoms anymore, and the suture were able to be removed. So for the result, the perioperative sample showed a pure growth of Pasteurella canis, and the pus swab performed in the emergency was negative. So as you surely better know than I am, Pasteurella canis are gram-negative, non-motile, aerobic or facultative anaerobic coccolobacilli. What interested us the most in this case is that those pathogens are usually found in the oropharyngeal flora of healthy animals such as dogs and cats. Facing this unusual result, we questioned again our patient, which admitted she adopted a cat 2.5 years prior to symptoms onset. She didn't remember being directly scratches or bitten on the breast, but she couldn't exclude superficial scratches or bites. So what can we discuss about this case? First of all, Pasteurella canis infection among humans or due to close contacts with animals, but the source of entry cannot always be identified. Pasteurella species are the most common pathogen found in cats and dogs bites. Eskende and al. Published a really interesting retrospective study including 958 cases of Pasteurella infection, showing that Pasteurella multocida and Pasteurella canis are the main species causing infection among humans, with Pasteurella multocida being the first one by far with 60% of the case, and Pasteurella canis being the second one with almost 10% of the case. The cutaneous infection represent the main form of infection, and then the respiratory tract and septicemia are the main form of infection unrelated to animal bite wounds. So, but what about the Pasteurella infection among prosthetic material? Our literature review first focused on breast implant infection due to Pasteurella species, and to date we only find 4 cases of breast implant infection, but those with Pasteurella multocida in the literature, what's made our case of infection with Pasteurella canis a first in the literature. When we compare those cases in terms of onset of symptoms, all symptoms occurred during the postoperative period between 13 days after surgery and 3 weeks after surgery. All patients admitted having close contact with animal. One patient had been directly scratched near the drain by a cat. The other patient admitted sleeping with her dogs. One patient had her drain chewed by a cat. And the last patient has only close contact with cats. The treatment includes antibiotic treatment for all patients. A direct implant or expander removal was indicated in 2 cases. A delayed implant removal was performed for 1 patient due to a failure of only antibiotic treatment. And in 1 case, the prosthesis could be saved due to an extensive surgical lavage and a draining. So those cases underline the link that can exist between close contact with animals and infection, mostly during the postoperative period, which is quite critical because the surgical wounds and the drain can constitute a major source of entry for those kind of pathogens. Secondly, our literature review focused on other prosthetic material infection with Pasteurella canis this time, and we found a case report of Mondon who reported a total knee arthroplasty infection with Pasteurella canis. The positive sample for Pasteurella canis happened at 2.5 years after the surgery revision. The patient admitting being bitten by a dog on the left hand 3 years before symptoms onset, and patient was treated with antibiotics and surgical cleaning. As in our case, we can mark that the onset of symptoms happened quite lately after surgery. So we could ask us, is there a latency period between exposure and the contact of animals and the onset of infection, or is just the exposure undefined by the patient who maybe don't remember being scratched or bitten by a pet? And the last research we made on the literature was among prosthetic material in general with Pasteurella species, but not especially Pasteurella canis. And we found the case report of Ferguson and all who reported a total knee arthroplasty infection with Pasteurella multocida. They also made an interesting literature review. So the case they reported, the onset of symptoms was 13 weeks after surgery. The patient was having 1 cat and 3 dogs at the time and admitted being licked on the leg sometimes by his pets, and was treated with antibiotics and surgical cleaning of the joint. About the literature reviews they made about Pasteurella multocida infection among prosthetic joint infection, they reported 22 cases of prosthetic joint infection, 17 including the knee and 5 involving the hip. The underlying factor identified in those infections were osteoarthritis, rheumatoid arthritis, steroid use, cancer, and diabetes. In the 22 cases, patients were treated with antibiotics, mostly with beta-lactam antibiotics or ciprofloxacin in second intention. 13 cases needed a joint revision, 8 cases needed a surgical cleaning with prosthetic salvage, and one patient needed a surgical cleaning with the change of the polyethylene spacer of the prosthesis. What can we conclude about all this is that there clearly exists a relationship between close contact with pets and breast implant infection. The perioperative period remains the most critical period because surgical wound and drains constitute a major source of entry for the pathogen when close contact with pets exists. They also may be a delayed infection, as in our case, and we could ask ourselves, is there a latency period where the patient is exposed during the postoperative period and the onset of the infection happen with a delay? Or is there just an undefined exposure, such as superficial scratches, bites, or close contact with pets that is not defined by the patient? I think as practitioner, we should put an accent on patient education about the risk of zoonotic infection. We should be questioning our patient about the pet's environment, particularly if there is an implant placement in the surgery that is planned. If patients are living with pets, we should explain them the risk and propose proper hygiene measures in order to avoid those zoonotic infections. The treatment in such cases is based on antibiotics treatment, mostly amoxicillin and clavulanate, and a surgical cleaning is always indicated with or without the implant removal. I thank you for your attention.